Now we are going to discuss about acute pericarditis. So this is simply inflammation of the pericardium. The normal amount of pericardial fluid that is present is around 15 to 50 ml into 50 ml. This acute pericarditis can be divided based on its duration of episode. It can be divided into acute, subacute, or chronic. Acute is less than 6 weeks. Subacute is 6 weeks to 6 months. Chronic is more than 6 months. More than 6 month duration. Now we'll see what are the causes of acute pericarditis. It can be divided into three groups: one infectious causes, non-infectious causes, and autoimmune causes. Infectious causes, the most important ones are the viral infections. So viruses, and it is most likely the Coxsackie virus that causes acute pericarditis. Coxsackie. But apart from that, there are so many other viruses that can also cause, like ecovirus, adenovirus, mumps, and HIV. Second group is the pyogenic group. Pyogenic causes include staph, strepto. TB can also cause acute pericarditis. Then fungal infections like coccidiomycosis, blastomycosis, histoplasma, and candida. Then there are certain other miscellaneous causes like syphilis or certain protozoans. Certain protozoans can also cause acute pericarditis, but the most important ones are viruses. Tuberculosis, of course, can cause acute pericarditis, but that will more likely lead to a chronic constrictive pericarditis. Okay. Non-infectious causes include chronic kidney disease, which is a very common clinical scenario that we see in our practice. Many of the cases are idiopathic. Then malignancies, like CA breast, CA lung, certain leukemias or lymphomas. So malignant infiltration of the pericardium, they can cause acute pericarditis. Remember, the malignancies that metastasize to heart, the most common location of metastasis inside the heart is pericardium. Okay. Then certain trauma or insults. Insults can be due to myocardial infarction or trauma, radiation, or aortic dissection. So we'll be studying myocardial infarction that acute pericarditis is seen in the acute setting itself, or it can be seen as a subacute manifestation of after the myocardial infarction, that is known as the Dressler syndrome. Then there are certain familial acute pericarditis causes. Familial. This is seen in familial Mediterranean fever, and one more that is known as mulberry anism. Then metabolic causes include myxedema, and sometimes cholesterol pericarditis is also seen. It's very rare. So these are the non-infectious causes. Most important ones are CKD, malignancy, and trauma. CKD, malignancy, and trauma related. Autoimmune immune-mediated causes include acute rheumatic fever, connective tissue disorders like SLE, Sjogren's like SLE, Then certain drugs like procainamide, hydralazine, ENH, minoxidil, certain anticoagulants. These are the drugs that can cause pericarditis. Now, of course, post-cardiac injury syndrome, post-cardiac injury, that can be included in the insults also. Post-cardiac injury, this is post-cardiectomy, post-cardiectomy, or post-MI. So, post-MI, as I told, Dressler syndrome is a post-MI type of acute pericarditis. Post-MI type acute pericarditis, and the mechanism is autoimmune. That's why I have mentioned here. So, in MI, two types of pericarditis can be seen, which can be seen in acute condition itself, acute episode itself, and another one is seen after 1 to 8 weeks of microbial infection, and the mechanism is autoimmune, that is known as Dressler syndrome. So, these are some of the causes of acute pericarditis. Most of the times, it is virus or autoimmune or injury related, and in our clinical practice, we have also seen CKD is also a very important cause of acute pericarditis. Okay. Now we'll see what are the clinical manifestations and how you diagnose. So you have to remember 4 important aspects under this heading. First one is what is the character of the chest pain that is associated with acute pericarditis. All the types of chest pain can be described like according to this mnemonic Socrates. S means the site. Site for acute pericarditis is retrosternal bar left-sided. Retrosternal bar left-sided, similar to that of microbial infection. Onset is of course acute. Then C for character. Character is pleuritic type of chest pain that is increasing on deep inspiration. Then R is radiation. So acute pain of chest pain of acute pericarditis can radiate, similar to that of myocardial infection. It can radiate to the shoulders and up to the jaw. But one important point is it can also radiate to trapezius. Which is not seen in patients with myocardial infection. Associated feature, nothing but specific. Timing, it lasts for minutes to hours. Exaggerated factors include supine position. If the patient lies supine, then it may aggravate the pain, and it is relieved by leaning forward. In severity, it is moderate in intensity, usually moderate to severe in intensity. This is the Socrates for chest pain of acute pericarditis. Site is retrosternal bar left-sided. Onset is acute. Character is pleuritic. Radiation similar to microbial infection, but along with the trapezius can be involved. Timing is minute to hour. Exaggerated by supine position, and severity is moderate to severe intensity. Now, on clinical examination, you may find a rub that is known as the friction rub. It is known as friction rub. It is the nature is scratchy or raspy or grating sound. It has 3 components, 2 in diastole and 1 in systole. Best heard if the patient is leaning forward. Sitting and leaning forward, the sound is best heard. Okay, so if you see this image, you can see here the patient is leaning forward and we are examining the precordium. This is how you can elicit pericardial rub in a much better way. Now, what are the ECG findings? There are 4 phases. The first one is ST elevation, along with that PR depression. These points I have already discussed in my ECG lectures. If you have not seen, you just go back and see them. Then in the second phase, ST will come to baseline. ST will come to baseline. Then there will be T wave inversion, and ultimately the ECG will become complete. ECG will return to the baseline ECG. So these are the phases of acute pericarditis. That means the findings are not persistent. The findings that we see in the ECG in cases of acute pericarditis, they are not persistent. After some time, it will resolve and ECG will become normal. So in the stage 1, I told diffuse ST elevation and there is PR depression. You can see here diffuse ST elevation and there is PR depression. This PR depression. What else? I have already told that you will get a concave upward ST segment elevation, concave upwards. In the stage 2, normalization of the ST segment and PR segment. Stage 3, I told there will be T inversion. Stage 4, coming to the baseline. Okay. If you see this ECG also, you can see there is diffuse ST elevation. Lead 1 is involved. Lead 2 is involved. Then V2 is involved. V3 is involved. V4 is involved. V5 is involved. V6 is involved. You can appreciate there is a concave upward, concavity upwards. And you can also appreciate there is PR depression. Okay. There is PR depression. And you can also appreciate that these ST elevations are in non-contiguous nature. They are of non-contiguous nature. Okay. And I have already told that the PR depression will happen in all leads except the AVR. In AVR, you will get PR elevation. AVR is the opposite lead. And it will have ST segment depression and PR elevation. Okay, so all these points I have discussed in my ECG section. So you have to see that also to understand it in a better way. One more point also I have told during my ECG lecture is the downsloping TP segment. Downsloping TP segment, which is very evident here. You can see this is the T wave. Then there is a downsloping TP segment. See, these are the downsloping TP segment. Now this sign is known as Spodek sign. Spodek sign. Downsloping TP segment. Downsloping TP segment. Okay, this is known as Spodek sign. These are all the findings you'll get in the ECG of a case of acute pericarditis. What will happen if you have effusion, associated effusion? If you have associated effusion in the ECG, you get low voltage complexes. And if you have a large effusion, you may get electrical alternance. How to define low voltage and what is electrical alternance? This also I have discussed in my ECG section. In chest X-ray, you may get a money bag appearance because of the effusion, something like this. And one important clinical finding that you should remember in case of effusion is Ewart sign. So what is Ewart sign? This is decreased breath sound at the inferior angle of left scapula. Because of the fluid, there will be decreased breath sound at the inferior angle of left scapula, that is known as Ewart sign. Okay, so these are the findings. If there is associated effusion with pericarditis, you may get these findings. Of course, you have to other investigation that you can do is 2D echo, CT scan. This is the money bag appearance. Treatment of acute pericarditis. The first point you have to remember, there is no specific treatment. Most of the cases are idiopathic or viral induced acute pericarditis. They are usually maybe sometimes they are self-limiting, but sometimes you may have to give treatment. But if it is associated with other conditions, then you have to treat the underlying cause. Treatment of underlying cause. Drug therapy include NSAIDs, corticoids, and colchicine. Any NSAID can be used, indomethacin, ibuprofen, naproxen, anything can be used for around 2 weeks. Glucocorticoids can be given for 2 to 4 days. 2 to 4 days you can give glucocorticoid to have adequate anti-inflammatory response. Colchicine 0.6 mg OD if the weight is less than 70 kg, or 0.6 mg BD if it is more than 70 kg. Colchicine enhance the response to increase the response of steroid or NSAIDs, and also it decreases recurrence. For the side effect of colchicine is diarrhea. Now, if the patient is not responding to these drugs, you can also use azathioprine or interleukin 1 beta inhibitor. Okay, and if still it is persistent, you can go for pericardiectomy, pericardial resection. Okay, surgery is the last resort if it is recurrent or persistent. That's all about acute pericarditis.